Good morning, ladies and gentlemen. Welcome to the North Broward Hospital District Board Commission, a special meeting, January 22, 2018. I'd like to call the meeting to order. I'm going to ask Joanna to please do the roll call.
Commissioner Rodriguez?
Here.
Commissioner Uri?
Here.
Commissioner Klein?
Here.
Commissioner Wellens?
Here.
Commissioner Gregoire? Here. Thank you.
Commissioner Wellens, you are up there. Would you lead us in the Pledge of Allegiance, please?
Yes. Are we ready?
Yeah.
I pledge allegiance to the flag of the United States of America and to the republic in which we stand, one nation, under God, indivisible, with liberty and justice for all.
Thank you.
You're welcome.
Joanna, do we have any comments from the audience?
I don't know.
Anybody sign up?
No.
Anybody want to speak? You got 3 minutes.
We'll speak at the chair.
You would sit in a chair. Hold on. I gotta get my buzzer, my electric buzzer.
This is a congressional meeting.
Yeah.
Commissioner Wellens can see you as well.
Congressional meeting. Good morning, board, Mr. Chairman, board members, Vice Chair, Vincente Thrower, part of the SCLC, and with me today is Pastor Alan Jackson, Pastor George Rich, and our president is running a little behind. Just here today to identify support of this process and looking to identify also that we would strongly be encouraging this body to look for a candidate that has a desire to not only work with the healthcare system, but looking for a desire for somebody who will look at community engagement, looking at the going back to what the CEO previously, Dr. El Sanadi, looking at the faith base, looking at how we all work entwined together. In our communities, as everybody knows, that the church is the heart of our community. And looking at how do we work in that process from church to synagogue, all those entwined is where we are, is where the heart of our base is. So as you make this tough decision, we would hope that you all will look for a candidate and make sure that during your interview process that you engage and ask them what is their relationship and how do they work in their system with their local communities and community leaders. That is what we're going to be asking of this body. You have our full confidence in moving this process and how you're doing this process. A lot of things have changed since the last time we came before you all, and we would talk about that at a regular board meeting. But other than that, we are looking forward to this process. We believe that you all are capable of making this decision, and we will be back and just be present. So if you all do open this process up for questions, that will still be the same statement. We will be looking for community engagement in our next CEO. Thank you.
Thank you. Anybody else?
Good morning.
Good morning.
God bless you. Good morning, Mr. Chairman, Vice Chairman, to the other board members, and it's a pleasure to be back before you again, particularly in a situation where you're looking to hire a visionary to move this company or move this organization forward. As a pastor of a few hundred people, you know, I constantly have to be in touch with the people that I serve. I constantly have to know the needs of the people that walk in our congregation every Sunday, every Wednesday, and all throughout the week. I think it's important for your next CEO to be in touch with the people that you serve, that we serve, that the hospital district serves. And so that's going to call for that next CEO to be a visionary, to have a vision for engaging the community. I worked for Pompano Police for a while. I worked for the Broward Sheriff Office for a while. I ran for County Commission in 04 and 08. And in all of my engagement, I understood the importance of community. I understood the importance of listening to the community and what the community wanted. And so as we move forward in this process and as you identify and interview the different candidates, you know, I hope that you will have that vision as well to be able to ask these candidates, what is your vision for the community? There has to be a connect. Dr. El Sanado was one of the greatest CEOs I guess you guys have ever had. His reach out to the clergy, particularly the faith community, where we had monthly meetings with him, was unparalleled. It was just amazing to be able to know the district, what the district provided, all of the things that were available, giving us access to know certain things that we would not have known if he had not built that relationship with us. And so we're asking this board to please consider and understand how important it is to engage with the community, particularly the African American community. So we'll be a part of the process tomorrow. We'll be here. We're going to be gauging things and just observing, and hoping that this board will choose the best candidate that really has a vision for community engagement, community involvement, the clergy. Our president is on his way, and we had a conversation the other day. The SCLC is ready to get behind whoever the candidate is and support that candidate and help that candidate move forward with the vision for the community. So I appreciate the time and the opportunity to speak to you guys this morning, and happy interviewing. Thank you so much.
Thank you. Anybody else? All right. Let me just give you a brief scenario here. What happened here? A while, about a little right around May, Commissioner Wellens and I were charged with bringing candidates out, so they were posted by our former HR. At the end of the posting, over 300 people had been interviewed, and the best 10 of those nationwide came to us. We then proceeded in a public forum to select, I believe we end up selecting 6, because I believe the Commissioner Yuri mentioned we should just add somebody else just in case. And so we selected 6. One is gainfully employed. I don't know about the other one, but 2 of them declined the offer, or withdrew, or whatever you want to call it. Bottom line is we got 4, 2 that will be interviewed today, and 2 will be interviewed tomorrow. And if we cannot find the best 4 amongst 300 across the country, there's something wrong with us. So I think it's about time that we move forward and get ourselves a permanent CEO. So having said that, you're all welcome to attend these meetings. They're all public meetings. I'd like to move and ask Mr. Nayamura if Barbara Martin is ready.
I believe that she is. I had asked them to wait outside, so let me just bring her in.
Okay. What we'll do is I'm going to ask candidates to give a brief, like maybe 5-minute introduction, then I want to allow them to see what the vision is, and then we'll have 5 of us will ask individual questions of the candidates. After that, each candidate will be going to, for what I understand, to one of the hospitals to meet with the clinical staff, chief of staff, and also with the leadership team. And then they'll come back. We're not going to make any decisions until all 4 have been interviewed. Good morning.
Good morning.
Would you have a seat? Would you join us?
Okay.
So good morning.
Good morning.
And let me introduce our commissioners here. We have Commissioner Gregoire, Commissioner Yuri, Commissioner Ryan. I am Rocky Rodriguez, and we have Mr. Ayamora, Human Resources, and Gino Santorio, the COO, and Alan Smith, the CFO. I mean, no, is that what it is, CFO? I can't see from here. I didn't want to demote you or promote you because you get in trouble that way. Anyway, we have the General Counsel, Ms. Barrett, and Johan is here with us.
We got Commissioner Wellman.
Commissioner Wellings.
We got Commissioner Wellens up on the, I'm sorry, I almost forgot you. You must be a snowed under over there.
Good
Anyway,
morning.
so the plan here is to, if you take about 5 minutes and tell us about yourself,
Okay.
and then right after that, we'd like to know, what your vision would be, what more or less you would do, and then we'll give you about 30 minutes, 20 minutes, whatever, and each one of us then will ask you individual questions. Is that, you okay with that?
That's perfect. Thank
Okay,
you.
so I understand that, just want to let you know, I was talking about this earlier. You four are within the top 300 and some in the country. And so I thank you for your perseverance to stick it out. I know it's been a really grueling process, and as you know, in government things move like molasses, unfortunately. So the floor is yours.
Okay. Well, thank you for inviting me. I'm Barb Martin. I actually started right out of college. I have a bachelor's degree in nursing. Went to a 4-year program and then got my MBA. Realized that I needed far more than just clinical behind me, and went back and got my MBA to really pick up all those other finance skills and all. I was in nursing for about 14 years, worked my way up from a staff nurse to a director of nursing to a chief nursing officer, and then was recruited by Whitkeefer, a recruitment firm, to leave the nursing side and move into hospital operations, which I did. Was recruited by Provena St. Joe's in Joliet, Illinois, and just happened to be, it was the right time for me. Had done it all in nursing and knew that I wanted to get into hospital administration. So I left there after nursing after 14 years, and the remainder of my career has been progressive experience, working my way up the ladder in hospital operations. My last position was the CEO of Vista Health System, but I actually went to, how I progressed through that, I went to Provena St. Joe's Medical Center as the vice president for ambulatory, which was very new, and built an ambulatory care network of a 30-mile radius of St. Joe's, which was the flagship hospital, the tertiary care center of Provena Health, which was a 7-hospital system at the time. Was vice president for ambulatory, and about less than a year later, they came and said, Barb, we need a chief operating officer, but we don't want you to leave the ambulatory side. I was recruiting docs, building buildings, sourcing land, building that whole network out there to supply those admissions and build a system of Provena St. Joe's. So I took on, my title was actually vice president for ambulatory, vice president for hospital operations and ambulatory services, which was the chief operating officer. So I was doing inpatient, outpatient, the entire gamut of hospital operations, which really is where healthcare is today, in and out. You just can't look at one thing, you have to look at a system component. So I stayed there. I was at the hospital as that role for about 9 years, and then the system office asked me to go be a system vice president for Provena Health. So I went out to the corporate office for about 4.5 years as the vice president for clinical operations. But they did not have a chief operating officer. They had a CEO, vice president for clinical. So I oversaw the clinical side as well as many of the operational side. And my role was really working with all those 7 hospitals. I always said those CEOs were my customers. If I didn't work with them, I was not going to be successful. So did that for another 4.5 years, and then the system had gone through a bit of turmoil, and we're looking at joining another system, and they had 4 CEOs during that 4.5 years. I was the only CEO who survived them all, and it was a great experience. And so what I chose to do, I'm a risk taker, an entrepreneur, so I decided I was going to leave Vista and went out and went out to Temple University Health System as my title was the Vice President for Clinical Operations for 3 hospitals, Temple University Medical Center, Temple Children's Hospital, and Episcopal Hospital. So it was really leaving and getting into a big tertiary university setting, which I hadn't done in my career, so I think, you need all those components to do what you want to do. So I did that for about 1.5 years, and then Provena came back to me and said, Barb, we have a joint operating agreement up in Waukegan, Illinois, Vista Health. We need somebody to come up there and lead a turnaround. They were in huge, the state senators were lobbying against us. The first day I was up there, they were picketing because the administration was going to shut a hospital down. It was, as I put it, a mess. And I, went in there that first day, and I'm thinking, it's a little different than I thought, but I just dug in, and it's been the best opportunity that I ever had. Led that system. There was the joint operating agreement broke up. Neither hospital could, as I put, play in the right sandbox together. So we got rid of the Vista Health, and we formed. I brought the 2 hospitals together, and having acute care at one hospital, behavioral health, acute rehab, emergency department, all those other things at the other hospital, and then built that ambulatory network throughout Vista Health Systems. Though when we brought the hospitals together, had been very financially poorly run. When I got there, they were losing $18 million a year, and I sat back and said, okay, what do we have to do to get into profitability? So led that turnaround. We needed a capital partner. We needed money to do the things that we needed to do. So I sourced it out. I led an acquisition. 8 systems bid on us, 4 for-profit, 4 non, and I led that acquisition, and we joined Community Health System, which was a for-profit system. They invested, they paid a couple $100 million. They invested $150 million. It was very, very good for Vista Health System. So I continued that turnaround, and we've been very successful the last 12 years that I was actually CEO. When I went there, I was the chief turnaround officer to the chief operating officer, and then was appointed the CEO from the board, and was the CEO actually for about 12.5 years at Vista Health System. And just recently, I actually applied for this position before I left Vista Health System, because this was on the market for quite some time, this position. And I had a friend calling from Loyola University Health System. So what I've been doing since I left there was the Chief Integration Officer for Loyola. I am an independent contractor though. So I'm working for the CEO, working through their acquiring a hospital.
How do you see Broward Health? I'm sure that you read a lot of stuff. We are often in the papers. But have you been able to sort of take a look at the system and so forth? And I know there's full of challenges, and we've been able to keep the organization going and without any with total regard for providing the health, and so we continue to provide the care to the residents of Broward County. But what's your take on the, more or less, in a nutshell, what would you vision and what would you do on your first 60 days or 90 days?
Okay. Broward's had some difficulty, there's no doubt. It's on the internet. I mean, nothing's secret anymore about anyone or anything. And, it's kind of, when I looked at this, when I first applied, it's kind of like what I went up at Vista Health System. In a lot of turmoil, they had a significant fine from the state of Illinois, all those things. And to me, that's just purely a challenge. And, going in, first of all, you have to meet the people, but you also have to build those relationships statewide, elected officials, locally, all those different components. That CEO of a system has to be out there building those relationships because, this is going to be a very visible position, whoever comes into this role. And again, that first impression, that ability to get in there and really communicate with those people, identify that, although Broward has been through some difficulty, many systems go through difficulty. And it is what it is. You can't change the past, you can only move forward. And I believe that Broward has a very strong core mission, vision. It's all about patient care in the end and taking care of the community and those people, but it's also about having the community, the state, and all those different components supporting, federally too, supporting this system to help build it to the next. That's what I did within Waukegan. I had Senator Terry Link, Representative Joanne Osmond, Brad Schneider, Bob Dold, those were all federal and state legislators who were my advocates. But boy, when I had to build that relationship with them. They didn't like Vista when I came. They certainly liked it when I left, and were very sad that I was leaving. And they're still very good friends of mine, which you never lose those relationships. But I would do the same thing that here. You have to also build that community support where they feel that this is the best system to come to, wherever those hospitals are. And it's through quality. It's through, when I was in Catholic healthcare, the women in religious or the nuns told me, no margin, no mission, Barb. So you got to make money, but you also have to support that mission, and you also have to support the community and be part of that. And that's a critical role of that CEO of Broward Health System. So, that's going to be your first 30, 60, 90 days is to building that. But it's also ongoing. It doesn't end. That CEO has to be out there, but also can't lose sight of the core of the hospitals, how they're doing, how we're expanding, how we're marketing. I'd really have to come in and get a feel of, I know you have 7 ambulatory care facilities, you have 4 hospitals, a children's hospital, and a variety of, a lot of service lines that I went through and listed here. You do some really outstanding things, but to evaluate those and really work through all those components and, building those and setting that strategy with the board, with the executive leadership of all the hospitals and the entire administration to move forward.
Yeah, it is a known factor that on the journey to provide the very best health care to our citizens, there is a political component and also community component that go hand to hand with it. I'm going to go ahead and open up for questions with Commissioner Gregoire.
First of all, welcome to Florida.
Thank you.
It's warmer here than where you come from. Our minority communities, and in particular our African American community, they're very concerned. They feel almost disenfranchised by our system. And we don't intend that, but I'd like to know what positive steps you would take very quickly to assure them that that's not the case.
Well, that would likely be one of my first steps, is to, and my hospitals are from an Afro-American community primarily, and it is the county seat of Lake County. And a couple of those people I talked about are Afro-American. The mayor of Waukegan, the first Afro-American of Waukegan, was just elected, and he is one of I was on his transition committee. He picked 5 people to be on his transition committee, and I was one of those. The only female, and then it was a diverse population. But I would get in and meet, there's core components of whoever they are. I can't tell you who they are today, but you're going to find...
They're sitting behind you.
Oh. I'd be meeting with you quickly. But, it's getting in and meeting with those people and getting to know, what their perception is of Broward, what are their needs, why do they feel that they have been left out, or whatever that component is, and really working to bring, because they are our patient base within Broward. They are the people that are going to support us and really work with us in the long term. So that would be one of my first goals, is to meet with those. I mean, those first 3 months are going to be meeting and meeting and meeting and meeting with the different constituents that are absolutely critical to this system, good or bad. I'm not afraid to get in there with the most negative people around to sit down and really work through those pieces and make them feel that, this new CEO is really going to support them and bring this whole positive position along with them.
Can I have one more?
You can have as many as you want.
Thank you. The press also has a fairly dim view of us at the moment, and we would like to try to correct that by being as transparent and open and honest with the press as we can be while abiding by our guidelines.
Sure.
How could you assist us in that task?
Well, it's all building that system, and I'm sure whoever the person is that comes into this role, they're going to ask about the board. And, I want to get to know each one of you very well and find out, you all may have a little bit different perception of some of the things that need to be done. But, I'm a very positive advocate with the press. And, you get the negative people. Wherever you are, you have the negative and you have the positive. And, I used to reach out to those negative people, press people, and really work with them and say, hey, let's work together. It's to your best interest if Vista Health System is the best. And, what do we need to do to help you understand the true, it's the truth about the board, about Broward Health, or about whatever. So, I just reach out to those people. I'm not afraid of them. It's all communication. So much of misrepresentation is how communication has gone on. And, the media at times can move it the way that they want, but they also like to do good stories too. That could be a success story that they love to cover, so.
Thank you.
Thank you.
You want to take a break for a little while? We'll get to somebody else, Commissioner Yuri.
But I have more when it's my turn again.
Commissioner Yuri.
Yes, good morning. It's me.
Hi. Christopher, okay, I was looking around.
Chris is fine. Good morning. Thank you for taking the time to
Thank you for inviting me.
Biggest challenge facing healthcare industry today, and what is the biggest unmet opportunity in your mind?
Well, the biggest challenge in healthcare is balancing, like I said, margin and mission and quality, because, those 3 components are going to truly make it is. It's not going to get easier. Medicaid, we don't know quite where the funding's going to be long term. Managed care, they're certainly not going to try to pay us more. But at the same time, we have to always maintain that highest level of quality and maintain our mission. So it's really balancing and competing. You got some pretty strong competitors out in this market. And it's, healthcare, there's competition and mega systems all over. And it's competing with them, maintaining margin, maintaining mission, maintaining that quality patient care, and balancing that. We can say it's all these other things, but at the end of the day, you got to go down to your core components and really build Broward to what it needs to be.
What would you say then is perhaps the biggest opportunity that you see as being unmet and something that would be, and this is industry-wide, not necessarily Broward Health specific, what would you see that opportunity to be, and how would you suggest
Well,
seizing?
I do think there's an opportunity for any CEO, which I did a lot of, and in fact, from the system that I came from, CHS Quorum Health, they still have me lobbying for them some in the state, because they need me and they need my relationships while I'm in the Illinois market to help them get through some things. But, you know, it's really the opportunity, for instance, with reimbursement and government cuts and all, is really working with those elected officials. And some people call them politicians. My state senator Ling told me we're elected officials, not politicians. So working with them to really help them understand what needs to be. I served on IHA, Illinois Hospital Association Board they re-elected me 3 terms, so I was on over 10 years. So there are only 11 CEOs that are elected by their peers across the state. And so that was our role, really working with the different political situations, working to really help the people understand what needs to be done within healthcare. What needs to be done with the assessment tax, what needs to be done with Medicaid reimbursement, what needs to be done working with managed care companies. I negotiated my own contracts at Vista. They let me the last couple years, and I think I identified on my resume where I went to every managed care company and negotiated, I thought, poor contracts for Vista and to others. So, I mean, it's really working with, you know, the people, the elected officials and all, to help move reimbursement to what it needs to be, but also working with different agencies from quality of care and all those different components.
All right. Looks like to me you've had both for-profit and not-for-profit
Right.
experience. So let's just say public versus private.
Uh-huh.
All right. It's a public tax-supported system. Our shareholders, if you will, are our taxpayers, the community. And we're committed to keeping it that way. What would you say, having been on both sides, the virtues and challenges of either?
You know, I have, and I think that's one of the merits of my experience, is that I have experienced both sides, the non-for-profit and the for-profit. And when I led the acquisition, I had no biases of what it should be. But, you know, I think at the end of the day, people say to me, when we joined Community Health System, you know, what is the difference here? And I said, you know, it's really, there's not a lot of difference. We pay taxes. You know, Vista Health, when we were with Community Health System, we paid $7 million to Lake County and the city of Waukegan. That was a great asset to them. And, you know, whether the taxpayers are supporting you, public or not, or non-public, you know, for-profit or non-for-profit, you're really working for the same mission, but you really have to work through those different components. You know, it's all, at the end of the day, we're providing health care, and we're really competing against other systems. So I don't know that I say there is a distinction, but there's not a distinction, because you have to look at it, just center on different venues of the for-profit, the non-for-profit, the public, the private sectors, and really work with that.
Okay, thank you.
Commissioner Klein.
Thank you, Mr. Chairman. Thank you, Ms. Martin, for coming in.
Thank you.
And spending time with us. I have questions in a number of different areas.
Okay.
The first thing I wanted to do was follow up in the area of community engagement. You had mentioned that's something you're involved with in your present and your most recent positions. What's your overall approach? Well, I guess looking forward, I mean, you talked a little bit about your history, but what's your approach going forward to community engagement? Specifically, how do you go about that? What would be your objectives here, knowing what you know about Broward County?
Well, you know, my objective or my strategy is personally picking the phone up and calling these constituents' offices. You know, I don't necessarily need I certainly, you want an administrative assistant, but I think those direct calls are very important. And because oftentimes, you know, I've had a mayor say to me when I first went to Waukegan, well, I'm not setting up a meeting till I talk to her on the phone. So I talked to him on the phone, and I went down to his office and met with him. And, you know, it's that one-on-one contact where they get to know face-to-face, you know, what you're all about. And, you know, it's the ability to connect by one-on-one communications with these different constituents, whoever they would be. And, you know, that I would, like I said, that would be the very early on determining that right up front. Probably the first week, who are these key constituents that I need to get out with? But again, you know, that communication, but just not the initial communication, it's also that follow-up, because this community back here are going to have some issues that they identify. It's very important for me to get back to those people and set up regular meetings with them to assure that we're following through in resolving these things that have gone on in the past. But it's that constant, you know, working with them. You know, medical staff, when a medical staff called my office, I always took the call if I was available. Even if I may have been in a meeting, my assistant would always get me out, because that solved the problem immediately. They don't call you just because they want to call you. Or if an elected official calls me, they're not calling me because they just want to call me. They would get me and we'd solve the problem right there. Or if I couldn't, you know, we would set up a strategy of how we were going to approach this and move on.
Okay, thank you. You've had a very extensive and varied background, a very impressive background. Of all the things that you've done, you know, what's the most important aspect that you would bring here, you know, to this new challenge?
There's no doubt it's my last 14 years of where I was within Vista Health System. It's going up into a community that was in complete disarray with the hospitals. You know, the current mayor at that time was actually, we were right by the Wisconsin border, actually went over to Wisconsin and asked a hospital to come build a hospital in Waukegan. And that was just crazy. And I knew that going in. And you know, it's bringing those, you know, as I put it at the time, it was dysfunctional, it was in disarray, it was losing money, it was very poor community relationships with all the different diverse populations, with the elected officials, and it's really coming in and building that, but at the same time, continuing to expand and build market share, continuing to zero in on service lines and build into a strong margin. Whereas, you know, before I ever went there, up to Waukegan, the nuns told me no margin, no mission, and I go back to that, you kind of chuckle when you hear that, but they knew what to do. And, you know, doing those same things, but really setting that very core strategy of doing that. So it's my last job, and really summarizing, bringing what I did there and really expanding into, you know, a broader county and building it to one of the top leaders.
Well, it certainly sounds like there's some similarities, some analogous instances between your going into Vista and and the position here, the challenge here. Knowing what you know thus far about Broward Health, what do you think would be the top priority here, like on day one?
Well, it appears there's community perception that needs to be resolved quickly. It's getting out there and really working with the communities and identifying those different constituents. There's many different constituents that make up a community, and really identifying who are those core. I already know one of them, one core area, but also finding those others. And you know, that could be day one, whatever, that first week. I always say when you start a new job, it's first day, first week, first month, and then you move on. But, you know, having those in a very set idea. You know, I wouldn't come in here not knowing, probably more than I know today, you know, what my core goals would be. But then, you know, also with the state, since this is, you know, a public organization, it's critical. The other components of political environments, elected official environments, all those different components, and really building that, but also getting to know Broward Health, the different hospitals and all at the same time. But I think probably that first day would be really figuring out those community components and political components that have to be resolved.
How would you describe your past interaction with the boards that you've dealt with?
Well, I've had wonderful relationships with the board. I had a board when I first joined Vista Health System. That was I call it the previous board of Vista Health. When we joined the new system, that board had to go away because we were going from non-for-profit to for-profit. So I was able to, I actually had to go in front of Lisa Madigan, the state's attorney, and get approval from her. And we formed from Vista, we formed a $46 million foundation out of Vista Health. And so I had to get that. So those people couldn't come, but I was able to keep my chairman of the board, which was an MD, Afro-American female MD, who was able to stay as my chairman for quite some time. And then I was able to appoint the different board members over the years, which were judges, attorneys, community people, a variety of different, and a very diverse board. So I continued to work very, very positively with them.
Now, one of the things about this particular system and the board is everything is public. The meetings are in public, the interviews are in public.
Sure.
You mentioned attorney generals. We've had some interaction with some government officials. We're operating under a corporate integrity agreement. Is there anything in your background that would cause any concerns in that area? Any hesitation going into that environment?
Absolutely not. In fact, they are my biggest advocates. Not my biggest, but I mean, I had a good relation. There's not an elected official or Lisa Madigan. We met this last summer with Mike Madigan to get a tax credit, trying to lobby with him. And, in Chicago and politics in Illinois is very, what do I want to put it, political also.
Oh, yeah.
And so, not much different in any, so I continue to work with all those components in a very positive. I would have no hesitation with that.
Now, you probably don't have your balance sheets in front of you or some of your financial performance. But
I don't, yeah.
Okay, but I did want to just ask you, generally speaking, about the financial performance at Vista. Over the last several years. There seems to have been some variability year to year. Net income was positive and negative. The EBITDA was fluctuating. Could you explain a little bit about why there was some of that fluctuation?
Some of that's based on the system, how they would fluctuate month to month. And that was one of the negatives of working with a for-profit, because what they would do, you were accountable for quality, goals of financial, all those different components. So pay for performance doesn't bother me. So that's how I made money or didn't make money. And how they flowed from month to month, it was very unique, because some months you'd go in and you'd get a negative first month, and then all of a sudden the next month you'd have $5 million EBITDA. So a lot had to do with the system and how they would allocate different expenses down to you. As you know, community health system, if you've looked at all into community health system, when we joined them, they were one of the leading healthcare systems in the country. Today, they're really struggling financially. That's why they spun off into Quorum Health Corporation that struggled. And so a lot had to do with how the system chose to push dollars down. We continue to, I will tell you that we needed, I fought for many years that we needed better managed care contracts, because the system was negotiating those for a long period of my tenure with them. Like I said, the last 2 years, they allowed me to personally go and negotiate all these managed care contracts, and that we were able to get very, very good contracts from the Blues, from physician, employed physician contracts to Humana, to Aetna, to all those different components.
And over what period of time was the managed care transition?
It was the last couple years. They used me as the template they'd never allowed a CEO to go out and negotiate managed care contracts within themselves. And I guess the CEO, Tom Miller, said to me, well, if anyone can do it, you can do it, Barb. So I said, okay, just give me the go-ahead, and I did. I personally picked the phone up and called the right person within those managed care companies, and we were able to negotiate very strong contracts. So some of that fluctuating you see as those contracts, would fluctuate. Or if something occurred at the system office with revenue management and a denial wasn't done properly, it could affect your bottom line. But, I was an advocate continually of identifying this and trying to work with the financial at the system office to resolve those issues.
So having worked through that, what's the lesson for here? How would you address that if you were to come to Broward Health?
Well, I'd want to work closely with the CFO and the executive finance people to really identify what are the managed care contracts like. How do you build those relationships with the different payers? I don't know exactly how contracts are negotiated, probably system level with the different payers. Medicaid, that's a luxury to be able to do it locally at the system as opposed to have a broader system negotiating. It's really, I get to know the payers. I mean, I know the head of Blue Cross from Illinois very well, and I picked that phone up and called. That was my first call, and we had a meeting 2 weeks later in my boardroom where they came in. He said to me, "I don't know why you never called me. We were kind of wondering." And we got a great Blue Cross contract out of that. Again, it's working through that. Finance. I know finance well, but I am not the chief financial officer, and I never wanted to be one. But it's working with that person integrally. You got to work with your finance people to work through the different pieces. And I'm sure Broward fluctuates month to month based on reimbursement denials. How well the different departments are working denials. I always said with these managed care companies, there's a lot out on the table there. They pay claims poorly because a lot of hospitals don't go after them. Well, you have to be astute to go after these people and really work with that.
Yes, and we're thankful to have a good staff here.
Good.
So,
That's always core, the finance people.
You got a great chief financial officer over there. He can tell you the square root of 9,837 stuff in a second.
It's a tough role. And, they can get blamed for a lot, but it's not them getting blamed. They're just doing the numbers. We got to produce the patients and, bring the people in.
well, I think in the interest of time, I'll stop there and
Okay.
Commissioner Wallens have a chance.
Yeah, Commissioner
you.
Wellens. We kept you frozen up there, so.
Good morning, and thank you certainly for giving us the time to come in today and I've come all the way down here to visit us. Apparently it was a little easier to get there from Waukegan than it was to get there from Colorado, so I apologize that I'm a little disadvantaged not being there and have the opportunity to see you face to face. Unfortunately, the tail end of your opening, I got a little, I didn't really hear. So I just want to address one issue just really for myself, and it may be a little bit repetitive, and then I have a couple of questions. Obviously, it's clear from your conversation that you've done some research on the district, and you know the situation we're in. Certainly the press has characterized or attempted to characterize the departure of you from Vista. Could you just again share what your perspective on why you left after 14 years? Because I didn't get that part, and you may have answered it, but I just didn't hear it. From my own perspective.
Sure, absolutely. If you look at my resume, I have long tenures in the 3 different organizations that I've been. A little shorter when I was a CNO, only 4 and a half years, which isn't short, but then was recruited to leave. The only reason I left, I had a wonderful 14 years with Vista Health and Vista Health System. The company Quorum Health and previous CHS, they were starting to have some real financial difficulties. And I had a couple CEOs of some systems call me and say, Barb, I think they're going to sell Vista Health System because they needed to raise capital, the company did. They were primarily much smaller hospitals, and so, the CEO of Quorum I know well. And that's exactly what they're doing. They have sold one of the hospitals, which I helped them with, Vista Medical Center West, to a behavioral health company. And that, what I decided to do is I had opportunities out there. And like I said, I had actually applied for the Broward Health position before I left Vista Health System. Was not, as I put it, I'm very intuitive, so I knew what was going to happen in the long run. I always want to leave after 14 years any place in a very positive way. And so I just chose to resign, and they're going to sell Vista Medical Center East. They're trying to really they'd like to get out of Illinois. Quorum Health would. Medicaid reimbursement's not the greatest in Illinois. At the end of the day, they would be able to raise capital, and so it was just the right time. You get to a point where it's the right time. I had built this system. I really chose not to be part of selling off piece by piece by piece, and at the end of the day, would likely move out anyway into a different position.
Okay, fair enough. That clarifies my question. Number two, because I think Commissioner Klein and Commissioner Uri covered a lot of my other issues, but I guess this is more of a personal question. If I were to ask the CEO of Quorum or people that were your superiors over the past, let's say, 14 years, what would they say your biggest accomplishment would be? And if that's a clear-cut thing, well, what do you believe your biggest accomplishment was as a CEO, as a leader, as a visionary?
My biggest accomplishment, I can say, and I think one of my references is the CEO of Quorum Health. I would say it is truly taking a system that was very broken when I came, extremely broken, in all the diverse areas of finance, of quality, of community support, of elected official support, you name it, it was there. I remember saying, what have I gotten into? And I'm thinking, there's nothing wrong. This is a great opportunity. And I took it from there, and I kept just pacing, moving along. And moving it to, when we had strong financial outcomes, building it from a 2-hospital system into a large health system in Lake County. And a leader, we compete. Vista competes against the Advocates, the Northwestern Healthcare, the Rush North Shore Healthcare. And we were able to compete head-on with these people and never missed a beat with how we worked competitively in market share and finance with them. And I actually built relationships with those different people. So, that clearly is my biggest accomplishment and what I would do over again and would continue to work with.
Okay. Secondly, on the opposite side of that, we've all made mistakes in our careers and things like that. What do you think the worst decision you made, and then what did you do to rectify it to kind of get past the decision that maybe you said, maybe I should have done something differently? Can you think of an example of where you made a decision where you look back later and say, maybe I need to do it differently, and how did you rectify that?
I guess I look at, I never take a bad experience as a negative experience. It's always a learning opportunity. Probably in my 12 years, 14 years, you may have hired an executive that you thought was great, or you relied on somebody's reference or whatever, and maybe it wasn't the right choice, and just didn't pan out to be. It's trying to, I always try to work with those people. I have many executives that are now CEOs or have advanced in their career. But working with that person in a positive way to decide that it's not working and move on to the next person that should be in that role. But trying to do with dignity and respect to the person, but also moving on. I would say, I think everybody makes those mistakes at times. You just try not to. So you learn from that. You learn, ways to recruit better. Maybe some service lines that we would have started that weren't the best. And, in today's environment, you have to really look at service lines that meet the community needs, but then also maybe lost leaders, but you don't lose too much. so, looking at that a little differently at times.
Okay, good. And my last question really goes to sort of vision. So, as the CEO of a system the size of ours, coming out of certainly the news and the things that surround what we're going through right now, how would you best, sort of present your vision to a couple of different constituencies? First off, obviously patients, and secondly, how do you approach, a 10,000 employee system that has, sort of various, opinions as to where we're going? I mean, what's going to be your approach day one with patients, and then number two, really importantly to the 10,000 employees that we have under our responsibility?
Well, first of all, they've got to know who I am. They've got to get to know me. Even though it's, 4 hospitals and a variety of different components, that visibility out in those facilities will be critical, especially in the beginning. You have to be out there and visible. Employees, to this day, when I started, I held bi-monthly round-the-clock meetings, and I went to every different site that I had and met with employees at, very set times, and I would get a packed audience every time for all the years that I was there. And as I identified, I had a few items in, and I'd bring HR, I'd bring finance. We had some things we wanted to cover, but at the majority of the meeting with them bringing up concerns, issues, questions, as I said, there's no secrets in healthcare or in a system, and probably the employees know more than you know at times of what's going on. And so of really working with them and, meeting with them consistently, they've got to know who that CEO of the system and the ability to approach. And, regardless if it's a CEO of Broward Health, they have to know who you are and really working with them, and then having confidence in your HR leadership, your VP of HR, your system VP, that they're going to, again, keep us posted, keep everything moving ahead in really solving those issues. I'm sure you do employee satisfaction surveys. I don't know how often you do them or you do, but having different surveys, but then also assuring that you're following up on those, you're developing action plans, and really working through those different components. So really working with the constituents.
Great. All right, and the last question I have is, if you've obviously done some time and research this, is there an avenue that we're missing from your perspective as a system? What you've seen in other places that have worked? Is there a type of care? Is there a facility that you think would be a beneficial addition to what we're doing? Are we missing something from your perspective that you think would be a focus for a short or long-term goal there?
Well, it's interesting. This page and on to the next, I listed all. If you go on your website, you have all these different services in alphabetical order that you have. And I was, you even do some organ transplants, and it's you have a pretty you have a very comprehensive service line throughout your system. I think the key is really going through all those different service lines and assuring and looking at those that they're meeting the needs of the community, that they're doing well, or if they're not, that what do we do to work with them and really continue to broaden them. I think what you really have to do to come in here, that would be something that I'd identify I'd really look at right up front to see, are there needs? Because you're going to hear it from the community constituents if there's needs that Broward is not meeting, and really working through that and identifying is this. But also, you have to work with the finance people to identify, a balance sheet related to it, and, working through those. So I don't think you're missing much right now, but again, this is just off your website, and really, I need to look more. I had a little difficulty finding quality scores in some of those. So really looking at all those components and defining. That would be certainly part of my strategy, would be to look at that.
Okay. Thank you, and I certainly appreciate it, and I'll yield my time back to the chairman.
Thank you.
Thank you. I am going to, I know that we set you up for 10 o'clock, but the reality is that we started a little late because we were waiting for Commissioner Yuri. And let's say it is what it is. You know.
Yeah, but she didn't know that.
Okay. but I don't want to take the time away from you because it's not fair. So I just got a few questions before I ask that you do your closing remarks, and most of these questions you can answer with one answer.
Okay.
It doesn't. I don't expect you to elaborate. Where does quality begins in the health system?
Well, quality is just the core of it all. It begins from day one, that patient. First of all, it's a perception of the system to get people to want to come to you. You know, quality in patient care is the core reason we're here. We have hospitals and systems. So quality means everything. And hopefully you did see the quality. I think I even provided proof of the different centers of excellence that we developed. Because,
Right at the patient's bedside.
Yep.
Thanks. How often you round? How often you round? Like you mentioned about.
Okay, yeah. Well, I wish I could say I did it every week at every place, but I'm out there if, you know, a good assistant can allow time. You know, with Broward and with IHAD, it would actually have to be where I would have blocks of time scheduled because I had driving distance between different facilities. So it was, I tried to get to every facility every month. My office was in one of the big medical center, so I was able to get out there much more, but Vista Medical Center West, Vista Lindenhurst, which was a really outpatient hospital without inpatient beds. I was out there, I was at physician offices and all. So I tried to get out there all the time. I met with my doctors, employed doctors. I tried to meet with them on their finances monthly and get out with my CFO and really go over those things. So, but it kind of depends on the environment and where you are, but frequently.
Let me ask you, on behavioral health and substance abuse, long before I served on this board, I know there has been a reluctance in this North Broward Hospital District to advance and be progressive in some of these areas, okay? Today we lose 2 people a day due to the opioid crisis. And while there's several institutions throughout the county that provide a lot of these services, I really believe that we're behind the 8 ball on these services. So would you look at a progressive way of advancing some of these partnerships with state and other agencies?
You know, behavioral health is critical. In every one of my institutions, we've had large behavioral health institutions, units. And, you know, the opioid crisis is huge in Lake County. And I actually served, until the day I left Vista, I was on the Behavioral Health Task Force for Lake County. There was only 5 board members that were selected by the County Health Department. And it was on lack of behavioral health services for the county, and then I was on the Attorney General's opioid commission process. So we were looking at the opioid crisis in Lake County and McHenry County and zeroing in on it. It's a huge crisis. Behavioral health, though, is a substance. You know, most patients have comorbidities. They have a medical illness and they have a behavioral health illness. And they go hand in hand. And it's really working with this. And, you know, people who have an opioid crisis problems often have had behavioral health problems that have not been treated properly. So it's core. I'm sure it needs to be built within the county and within Broward Health, but it's critically important to a whole healthcare continuum. So very, very familiar with it, and I
especially a lot of
passion
it
for it. Yeah.
affecting the homeless and the veterans and a lot of these other areas there. Our goal has been, I know that my goal has been from day one to eliminate taxes. In other words, that we are sufficient in how we handle our finances, that we can make the dollars where we can in order to eliminate the tax burden, and we have consistently, at least since I have been here, and prior to me, a couple of my predecessors have eventually dropped whatever we can, because you can't drop, every year the same amount, but we have been able to drop between $3 and $5 million every year, and our competitors down in the South, they're almost down to nothing. So would that be something that you would support, to eliminate the tax burden on the taxpayer by creating programs that produce the revenue?
Oh, absolutely, and that refers me back to one of the questions, that as you have a lot of service lines, and very important ones, and I think if I understand your question correctly, it would really be zeroing in. You're going to have loss leaders, and you're going to have the cash cows and service lines, and you really have to balance that component to continue to be profitable and continue the margins and increase the margins that you want to do. But many of those loss leaders, or the ones that lose money, are ones that are very, very important to the communities. I mean, behavioral health is an example. It's very tough to make money in behavioral health, but it's critically important, and you can get it where you're neutral, or you make a little money, but then you're going to have some of your other programs that you have some really great core components that you can really get strong profit margins.
And another thing is that if you catch them at the front end, you don't have to spend the money at the, because it becomes a revolving door. And, I told someone one day, if we could eliminate substance abuse and a lot of this behavioral health, our jails will probably be empty, unfortunately, A couple of more things, and you mentioned the state importance. It's very important to be wired to our state legislators and our county commission, because like right now, we're in the middle of session, and there's new bills coming in every day, and we have been very successful in the past and more or less monitoring, and we've been very effective in the past maintaining the funding, so forth, because we got like a LIP funding, which is for low-income pool that we have to watch every year.
Sure.
Otherwise, so I'd like to hear that from you. So let me ask you this: suppose that you were to be the person chosen for the job, how long would it take you to have your boots on the ground? Depending on...
Then I walked in the front door as the CEO?
Yeah.
Oh.
I know you're probably going to have to move and find a home.
Yeah. Where I am, my contract is 30 days notice. So, I would give the 30-day notice. I'm very comfortable with moving. During that process, I'm sure I would be facilitating, looking at places, doing whatever needed to be done. I would suspect that I could have my boots on the ground, as you put it, within 6 weeks to 2 months at best, maybe sooner, if they would, because I have a very collegial relationship with the CEO of Loyola University Health System. It would just be working through that, but I would think anybody would want to give, unless I guess you're not working and you can come next week. I would say as small as 30 days to 2 months at best. And it's just everything moving, the whole component.
Okay, let me ask my fellow commissioners, do anybody else have any other questions?
What attracted you to Broward Health? Why do you want to come to us?
Well, like I said, I was still at Vista when I actually applied for this job. And, it just reminds me of when I went up to Waukegan. I love challenges. you know, in my point in my career, I just don't want to go do the same thing when you come in. You got a very strong, stable hospital, and just come in just kind of as a person. I like to come in, I like to make change in a positive way. I like building those relationships. You know, I'm a people person. Probably comes from a bit of that nursing background, but I also have that business acumen that I need. So this was, although, you know, some people have said, make sure you read about Broward. I said, I have, thank you.
We can help you with those challenges.
Yeah, well, that's okay. There's nothing wrong with that. Systems go through unique times, and I have the luxury, whether it's luxury or not, of going up to Waukegan and having a very similar situation and just diving in and tackling it and developing a very strong system quickly. And it's not in the last 12, at the end of my career with Vista, it was in the beginning that I just dove right in there and built, I would say Vista Health System has the strongest community relationships and state relationships of most systems in the state of Illinois. And that's just really hard work, and that doesn't scare me at all. I like those challenges. So that's really what drew me to this, a real challenge. But it's not insurmountable by any way, shape, or form.
Thank you.
All right, since anybody else, if not, I'm going to ask Ms. Martin do you want to give us your 3-4 minute closing remarks?
Sure, absolutely. Well, first of all, thank you, all of you, for inviting me. I was honored just to be, I think, one of 6 people to be selected. That is an honor.
One of 300 and some, it was actually.
Well, that's, I hadn't heard the 300.
To raise the bar a little bit.
Yeah. But, you know, I'm delighted to be, you know, selected in that role to come down here. You know, I believe you asked a core question. Why would you? You know, this is what I'm looking for. And I knew when I was still at Vista what Broward Health was. And it really said, you know, you get to a point after 14 years and you say, okay, it's time to move on. Let's get into your next challenge in life. And this would be a challenge, but just a very positive challenge. And I come in with those skills of coming into a very troubled system, hospitals, a community, how they're perceived, et cetera, and working and building those relationships into strong relationships. I come in with a financial turnaround. We're losing a lot of money, having to join a system because there was no capital in the bank. I come with that experience. I come with building lack of quality care into strong centers of excellence, into being, you know, when you're a center of excellence, you're a leader and you have to prove it to the governing bodies, and you're surveyed every year and you're turning results in. So it's not something you get one time and then you move on. Much even tougher than Joint Commission. And Joint Commission's not easy. But, you know, I have that progressive experience, so I really feel I've done all those different pieces within healthcare. So I could come in here on day one, whatever number day it would be, and just jump in and get moving and really identify those constituents and the hospitals and really be hands-on on the ground running from the day I arrived. And, you know, that's exciting to me. It's a challenge, but it's not something that, you know, I'd leave here today and say, I don't want to, you know, do something like that. I knew when I came down here what I was coming into. It's certainly, you've all been very gracious and great people, but I think I have that experience that it takes to lead Broward Health to the next level that it needs to go. And, you know, in a year from now being considered, and the board and all being considered one of the top leaders who stuck it out and moved it to where it was in the future. You have a great core base here, and the core is what it's all about, and then moving up to the next level and to the best level it can be. And there's great growth to occur here.
Well, we thank you for joining us today and allow us to grill you and question you and with all these questions. And
It's okay.
And we wish you luck and are you going to see the doctors now? Okay, and maybe we can, you want to
Yes.
Give us what the itinerary is now.
Absolutely. Thank you, Barbara, for joining. I know it can't be easy to do this kind of interview, so we have a nice agenda set up for you. You'll be heading over to the Broward Health Medical Center to meet with system leadership, and then after that you'll meet with the medical staff leaders as well, and get an opportunity to have a tour of that particular hospital. So we're excited, and I know you have to leave, I think, 2 or 2:30 today for your flight, so we're excited to show you what we're all about.
It's been a lovely visit. O'Hare was easy to get out of and get down here, so it's great.
I don't have a good time when I go see my daughter in Wisconsin.
Yeah.
Getting out of here. But God, what they say, Godspeed. Good luck.
Thank you.
And we will we have to interview all the 4 candidates before we get into our powwow. And
Yeah, I guess I was the kickoff, so that's
Yeah.
okay.
Now we have to wait for the grand finale.
But your staff did a great job of organizing this, and it was very unpainful for me and seamless, so I thank your staff too.
Thank you, Bob. It's really my team that did all of that, so I'm just grateful I have a good team, so thank you.
Peter even texts you if you reach out and call, so you get a text back, so I really do like that.
No, these guys are great. You know, they're great.
Well, thank you.
Thank you.
so much.
Great.
Thank you.
Thank
Enjoy
you.
the rest of your afternoon.
So, hey. Well, everybody's still here, so good morning to everybody. We're on the second part of our interviews, and since we are fair and balanced in this committee, we are starting a little bit late, but I'm going to make sure that we give our candidate the full hour that was supposed to start at 10 a.m. So we're getting out of here a little bit later. It's worth it as long as we can give everybody the fair share. So I call the meeting to order. Joanne, can you do the roll call?
Commissioner Rodriguez?
Here?
Commissioner Yuri?
Here.
Commissioner Klein?
Here.
Commissioner Wellens?
I'm here.
Commissioner Greenwald?
Here.
Okay. We have any comments from the audience? Having heard none? Okay, this is the candidate interview for President and Chief Executive Officer. We have Mr. John. Thank you very much. I want you to know that there were more than 300 applicants. You were one of the 10 that came to us. Then you became one of the 6 that we picked up. And now you're one of the 4th because one withdrew and I don't know what, was employed or whatever. I thank you for taking the perseverance to hang in there with us. They say that, those good things happen to those who wait, and I'm a firm believer of that. But you know how it is in government, sometimes things go as slow as molasses anyway. Here's going to be the process. I am going to ask you to do your opening remarks. Following that, maybe can give us a, what I'd like to do is pause after the opening remarks in case anyone has any questions. Then you can give us an idea of what your vision is for Broward Health. Then I will open it again for questions, and then you have your 5 minutes closing remarks. So thank you for being here. I hope you had a nice trip, and you're on the hot seat now, so give us your best shot.
Thank you. Mr. Wellens, good morning. I've had the chance to meet everyone, so it's nice to meet you as well. I'm Mike Young. I'm a seasoned executive. I have a 30-year demonstrated record of accomplishments. I believe the chief role of a chief executive is setting strategy, but then I think what differentiates success from not success is the development and execution of the plan within every part of the organization. So everybody in the organization knows what's important. Everybody is measured. Everybody is rewarded when the organization does well. And you achieve those things by developing a culture of high reliability and accountability. You do it at the front reception desk, you do it in the ICUs, you do it in the OR, and if you do it across your 9,000 employees, pretty soon you're doing wonderful, wonderful things. I have a history and experience in developing new programs. I built the first new women's hospital east of the Mississippi in 2000 in Lancaster. And at Pinnacle, we had a spectacular cardiovascular team, and we were very early in the TAVR trials and are now one of the leading TAVR centers in the state of Pennsylvania. I developed one of the first ACOs in Pennsylvania, developed a 6-hospital HMO back in the 1990s, partnering with 5 regional hospitals, and served as the chairman. So we find out what the community needs. We find out what's available across the country. I call it shooting in front of the duck. I went geese hunting one time with guys who knew what they were doing, so they let me take the first shot, so I shoot and I aim, I hit 5 feet behind them, and the second one I hit 3 feet in front of them, and finally I did actually wing one bird. And I think that's part of the strategy role. How do you get the organization to implement a program right at the time that the community needs to have it done? And I have a strong history of doing that. I understand technology, in which today in healthcare is really important. I've done 2 major installs below budget and below time, so I understand IT. I understand clinical technology because of my college background. And I know how to marry the two. Back in the late 90s in Pennsylvania, there was a malpractice crisis. Surgeons were leaving. So I went to the surgeons and I said, we'll get enough additional cases for you through the OR that you can pay the increased malpractice cost that you're facing. So I went out and found an OR program that was developed by the guy who ran the Chicago airport. And if you think about an OR, it's exactly like an airport. The patients are planes coming in, the doctors are the pilots, somebody has to be there to refuel, that's anesthesia, you have to get the food there, so it's a very complex thing. So we installed that in the late 90s. The first hospital in the country. So we now talk about OR start times and OR efficiencies and turnaround time. Well, we initiated that 20 years ago in Lancaster, Pennsylvania with a company called Perioptimum. It brought an additional 5,000-6,000 cases to Pinnacle, and it allowed the surgeons to stay in Pennsylvania instead of going across the river to Maryland or Delaware. I've learned through the years of driving successful change just because of the mentors I worked with and the fortunate or unfortunate circumstance. So in Pittsburgh, My mentor got myocarditis, and we operated without a CEO for a year and a half. So we really had the opportunity to do a lot of things that young executives may have not been able to do. And then in Lancaster, the CEO retired. He was 65, I was 35. So there was tremendous change in that organization, and obviously in Buffalo and Grady and even Pinnacle. So I've learned how to change organizations without breaking them. I think it's easy to change them, but it's not easy to successfully change them and make it operate better. I'm a strong communicator. I've been the CEO of public hospitals 2 times. This is an unusual situation. Meetings are public. There are certain requirements that you have to fulfill. I've done that twice. I understand what that means. I understand what a CEO can and can't do. I know what your role is as a public trustee. So that's a very unusual experience that I've had the pleasure of doing it twice. I think once you have the plan set, once you have the culture set, you need to be deliberate in moving towards the goals, but at the same time you have to be flexible. Many people think healthcare systems are hospitals and buildings, but I know that healthcare systems are people, so you have to be flexible. Not everybody moves at the same speed, not everybody has the same background. So hopefully at the end of this process, my goal is to be the key architect of the organization. I want to be its key change agent, and I want to drive and motivate the team to be successful in addressing the challenges that are currently here in healthcare, and I think are going to get bigger and bigger challenges as financing gets more difficult and the costs continue to escalate and the baby boomers continue to age out and seek more and more healthcare. So that's my formal official opening. I think the important part is answering your questions, so maybe there I'll stop there and let you ask your questions.
Hey, thank you. Any Commissioner Braywood?
Mr. Young, sitting behind you are some of the leaders of our African American community. Part of our problem is our relationships with the minority communities in the north part of the county. How would you address that? What positive steps could you take?
I believe in studying the community, and every community has unique clinical issues and socioeconomic issues. So the first thing you do is you find out what those issues are. So I learned in Atlanta, that has a very large African American population, we had a spectacular sickle cell program. And when I moved to Harrisburg, which also has a high African American population, there was no organized sickle cell program. It was a big community void. So we plagiarized a lot of what we were doing in Atlanta on a slightly smaller scale. So it's really working with the community, understanding what the needs are, understanding what services are available in the community, and then, like every other community, you address those. So if there's a primary care shortage, it's the organization's responsibility to provide that. If it's maternity care, you get the organization to address that. So it's really embracing and partnering with every community, and I have a lot of experience in doing that.
How would you go about finding out what those needs are, though?
Well, you sit down and you talk to them. You take, I'm sure the state of Florida has tremendous demographic and healthcare information. In Pennsylvania, we have PHC4, so you can measure by zip code how many doctors, by what type, what the population is, what outcomes are doing well, which ones are not. Diabetes, sickle cell, heart disease, how do you get those services to the community? But you do it through analytical research, you do it by market analysis, physically being there and talking to the community leadership as well as just the people who live in the community. So it's a process, and frankly, one of the best things that ever happened to me, I wanted to go to dental school and I got good grades, and I did well in the academic part of the test, but I'm blind in this eye, so that's why I'm kind of sitting this way. So I flunked the visual part of the boards, and so I interviewed everywhere, and they said, you can't be a dentist, you're blind. So I became a salesman. and I sold pharmaceuticals, and I got a lot of training in listening and understanding. So the process is really sitting down and listening. It's getting the academic and mathematical facts and meeting the needs. So for example, in Lancaster, we partnered with the AME Bethel Church through a pastor by the name of Louis Butcher, and he had a very small clinic in his basement of his church where physicians volunteered. So we stocked it and built it and staffed it for him. It operates to this day. 15 days later, he just retired a couple weeks ago, so you could call and ask him how we partnered with him. And then one Friday afternoon, I got a call from Southeast Lancaster Health Center, and they said, could you give us $45,000 because we're not going to make payroll, and it was obviously important that they make payroll. So we lent, I called the board, and we lent him the money, and I said, but I'd like to put my operator on your board so that we can find out what the problems are. So we bought them computers, we taught them to build, and they were on this third floor of a governmental building with no elevator. It was the worst thing I've ever seen. So we got our foundation to donate $750,000 to them, and our medical director became their medical director, and now it's one of the best FQHCs. So it's understanding, and it's right in the community, so it's understanding what the community needs and needs it. It's not us going into the community saying you need this, you need this. It's really understanding.
And then my second question is, how would you articulate with the press?
I learned very early at Grady, actually at Lancaster for that matter, that the press has a job to do, we have a job to do, and so if you partner with them and explain to them what the issues are and why you do what you do, and if you do the right things, oftentimes you get good press. So in Lancaster, it took a while. I was telling the story a little earlier while I was waiting. In Lancaster, they have a unique population called the Amish. So not many people know about the Amish. So we went to the Amish, and they have 13 bishops, and we found out what their needs were. And there was a polio outbreak in Philadelphia. And when that had happened 20 years before, polio came to Lancaster. Second biggest business in Lancaster is tourism. You obviously don't go on vacation where there's a polio outbreak. So I went to the bishops and I said, are you opposed to vaccination? He said, no, that's a misunderstanding, but it's just inconvenient to get your 4 kids, put them in a buggy, take them downtown to get vaccines. So we started a program called Child Protect, and we went out to the fire halls in Quarryville and Burdenhand and all these small communities, and we immunized 35,000 Amish kids. And then talking to the community, we found out there were 20,000 kids in the city who didn't have vaccinations and had problems when they turned 6 going to school. So we immunized all those kids in the fire halls in the city, and then we decided to immunize all the kids for free. Why should we give this group and not this group? So it's really communicating, and so we began to turn the philosophy around, and the press is now a big supporter of Lancaster General when they weren't when I first got there, and the same thing with Pinnacle Health. If you do the right thing and you deliver the right care, the community understands it. So I have experience in doing that, but when I first went to Grady, I was there a couple days, and we were in the newspaper for a patient had passed and somebody stole his wedding ring. And we were in the newspaper for those kind of things. So as we began to do the right thing and rejuvenate Grady, the press became our biggest supporter because they knew what Grady was before and what Grady is today.
And then my final question is, what's attractive to you about Broward Health?
I was trained in the sciences, and I had the experience of working in Lancaster for 18 years as CEO, where it was almost a closed community. We had 500,000 people there. We were the NICU, and we were the open heart surgery and everything in between. So we had a responsibility for the community, and that's where I learned this community model. And then when I went to Erie County Medical Center, a public hospital, and then Grady, the public hospital, I really learned the special place that public hospitals play in the health system nationally. So you know, I've gained a passion for that. And in addition to that, you have the scope of services from NICU to open heart to children's hospitals, where I have experience, and being responsible for, you know, a set population here in Broward County, and the weather's not too bad either. So I really enjoy the public hospital model, and I look forward to getting back to that.
Thank you very much.
Absolutely.
Commissioner Uri?
Sure, thank you, welcome. In preparing for today, I happened to look through, and I just would be interested in your, I guess, decision to leave Pinnacle at a time when you were integrating a new acquisition. I guess it's going to, if it hasn't closed, it's going to close this first quarter. Maybe you can help the board understand what occurred with that.
Yeah, I was brought into Pinnacle 7 years ago by the chairman of the board, who was the prior EVP of Highmark, the third biggest insurer in Pennsylvania. And he was chairman of an HMO that I interacted with for 18 years at Lancaster. And the prior CEO was retiring, so he asked me to come. So by the time the 6.5 years had expired, I was on my third board chairman, who wasn't on the board when I came. So what drove the merger model was the growth of really only 3 insurers left in Pennsylvania. So we had an attempted merger with Penn State Hershey, and it was a perfect complementary fit. We do primary and secondary and some tertiary care, and they do all tertiary care. It was like putting tires on a car. It was perfect. So unfortunately, the federal court approved it, but at the appeals court we were overturned, and so we were prohibited from doing that. And our medical group was very successful in reducing admissions and ER visits, so our cost of care was below the 85% mandatory target. So that was money we were leaving on the table. So we were looking to partner with an insurer. If you remember, as I said, 15 years before, Pinnacle was one of the 5 hospitals that started Health Central, so they believed in the concept. So we went to all the other insurers in central Pennsylvania, none of which were interested in partnering. So we went to the University of Pittsburgh, where I had trained, and I knew both the delivery leadership and the health plan leadership. So we drove out to Pittsburgh in December, and it was a very good meeting. Our board leadership, their board leadership, some board leadership from other institutions who had come in, so they could clearly explain what it was like for them to come into UPMC. As we're driving back 4 hours, it was, yeah, well, we could see ourselves doing this, but there are 4 things they wanted. The board wanted more board seats. They wanted paid to make the transaction happen, which UPMC didn't do. They wanted control of Pinnacle for a little longer than UPMC did, and I forget what the 4th one was. So my job was to negotiate those 4 things. So the UPMC board was 26 or 27. We were going to get 3. Having a 4th out of 31 was important but not critical. So I was able to negotiate with UPMC, and we got 1 of 5 seats on the health plan board. So having 1 out of 5 is more important than have. So we got that. UPMC agreed to pay us a significant amount of money, over $1 billion, and they agreed to lengthen the time. But unfortunately, we were acquiring 4 CHS hospitals. There was a prescribed time frame, so we had time pressures that you wouldn't have in a normal merger. So we had to move this pretty quickly, and I had a philosophical disagreement with some leadership on the board about whether UPMC was the right decision or not. So while the board vote was 16-1, the one person was adamantly upset about picking UPMC as a partner, and so that created a very difficult working environment.
Okay, thank you. Having been in the industry and obviously seen a lot of change, as you sit here today, what do you see as the biggest challenge industry-wide, not necessarily Broward Health specific, and then what would you say is perhaps the biggest opportunity to seize?
I think the biggest challenge is our financing is going to continue to be difficult. If you read Becker's Hospital Review every day, you see everybody's bottom line is down by half or 3/4, and fortunately they've done well in their investment portfolio, but operations are getting very difficult, and I think as governmental budgets get more and more challenging, the financing is going to get more difficult. So it's how can you get the efficiencies of care? But the next biggest challenge is also the next opportunity is the delivery of care is changing almost faster than the ability for organizations to change and meet it. You know, I remember 60 years ago when I had one of the first pediatric cardiac caths at Penn, you know, I was in the hospital for a week, and now 70% of our caths are outpatient. So that really changes the whole delivery model. It changes the physical structure. If you're going to do 25 outpatient caths, you need to have 25 outpatient recovery bays. But when you built the cath labs 10 years ago, they were all inpatient. So the physical delivery of care is changing. Then particularly in the cancer, and not too far behind heart disease, you're seeing genetic manipulation that allows to treat care versus chemo or radiation, where now you need to have a robust laboratory and robust scientific leadership to get you on that cutting edge. And I think that's the exciting and rewarding time. But at the same time, it's going to pull thousands of admissions out of the inpatient world. And so you have to meet, you know, I call it the foot in two canoes. You have to keep the inpatient world successfully operating, but you have to grow and be in a leadership position on the outpatient side. So in 1990, I built the health campus. You should Google Lancaster General and look at the health campus. It's 600,000 square feet of nothing but ambulatory care. It was the first one in the United States. Everybody's been in to model it. You walk in and register, you get your x-ray, you get your lab, and by the time you get to the doctor's office, your lab test is there and your x-rays are there. And that was, 27 years ago. It was radical. I remember many physicians didn't want to move out there because they wanted to be across the street from the hospital, but now 25 years later, they're all out there. So it's being able to see the opportunities and grasping them. So I think here the big opportunities on the ambulatory side, community-based activities, and having care. So if you read the resume, it talks about 10, 20, 30, and that was the strategic plan at Harrisburg. We were an acute care hospital downtown, no parking, right, with the river on one side and the state on the other. There was not much room for expanded. So our strategy was we wanted to have a primary care office 10 minutes away from wherever you lived, an ancillary site 20 minutes away, and then an acute care site 30 minutes. So our market's bifurcated by the river, and on the West Shore we didn't have a hospital. So we built a 110-bed hospital for $95 million. HCA couldn't figure out how we did it that low. It's won national awards for being pretty, and it filled up in 8 weeks. We developed ambulatory sites there. We developed primary care sites all through the community. We developed urgent care centers. So it really wasn't an expansion of ambulatory care so much as it was this expansion, or inpatient care. It was the expansion of ambulatory care. And so it's that balance. How do you keep the hospital successful, and how do you meet the new cutting edge? But I have a lot of experience in that. First surgery center in the state of Pennsylvania, I built it in Pittsburgh. First ambulatory center, comprehensive center, I built in Lancaster. I've brought large radiology groups in. I brought urgent care center groups in. So it's really part of that cutting edge knowledge of what's coming next and being prepared. If you do it first and you do it well, it gives you tremendous opportunity and positives in the marketplace. I believe healthcare institutions are either spiraling up or spiraling down, but if you do ambulatory before everybody else and better than everybody else, you capture more patients, you spiral up. You build a women's hospital and change the delivery model, you spiral up. You build a new hospital where they need it in Harrisburg, you spiral up. That generates more capital. You use that capital to build the next program. So while it's a challenge, it's an exciting challenge, but it's really an opportunity for organizations that can lead the change and be successful in it. I'm sorry, that was a very long answer.
No, it's great. My last, I guess, area, and then I know my colleagues have questions of their own, but in some of the areas that I'm interested in too. But we're a not-for-profit, public tax-supported system. Our shareholders, if you will, are the community, the taxpayers. Those are the folks that we answer to as a system, as opposed to a board or some other group, and we want to keep it that way. What would you say, in your experience, has been some of the virtues and challenges of that setup?
Well, that's one of the reasons why I'm here. You're not-for-profit, you're community-based. I had the opportunity to stay in Fort Wayne and be the CEO of an 8-hospital system. They do transplants. They're one of the biggest providers. But the for-profit model did not suit me. So I told the board chair I would stay until you get a leadership team in place, of which I've done. So I believe the not-for-profit world is what suits me, and I believe in partnering. So in the late 80s, the city of Lancaster was in economic trouble, and so we began providing a pilot. It got them almost over the hump, but not over. So we took over their workers' comp, and we got 100 employees back to work. In Harrisburg, they filed for bankruptcy while I was there. So we tripled our pilot, and we doubled our pilot with the school district, where Harrisburg wouldn't have been able to stay alive. There would have been no policemen. And so I think that's part of the specialness about the not-for-profit world, the governmental healthcare world, that is what's attractive to me. That said, good patient care is always cheaper. If you're not readmitted, you save $8,000. If you don't get an infection, you get the hospital saves $30,000. If you don't return to the OR, you save $10,000. So if you deliver top quartile, top decile care, it's always cheaper. So if you get paid the same as everybody else and your care is better but your cost is cheaper, you'll have enough margin to recapitalize to the new cutting edge program. It's part of the spiraling up. So if you look at all the places I worked, we were always the low-cost hospital. R.R. Donnelly, who only believed in they print Reader's Digest and annual reports, they only wanted to have one factory per town for various reasons. They moved 2 more factories to Lancaster, Pennsylvania, because our cost of care, which was their third cost of insurance, was so much cheaper. Armstrong World Industries, who made these ceiling tiles, their lowest cost for delivering care was in Lancaster, so they kept building factories in Lancaster. So all those things are coupled, and if that's the one takeaway, that you get is, after being a CEO 4 times, I understand how all the pieces go together. You know, I closed a pension plan. There aren't 100 people in America who successfully did that. But at the same time, we increased our 401k contribution because we wanted to make sure we implemented mandatory participation for all new employees. So doing the right thing clinically is also the right thing corporately, and both of those things will allow you enough margin to do the right programs, which goes back to now you're again doing the right thing clinically. So if you see that spiraling up model that I talk about, they're all intertwined.
Gotcha. Thank you.
Commissioner Client?
Thank you, Mr. Chairman. Thank you for joining us.
Good morning.
Some of my questions that I had related to balancing financial performance and quality care, and I think you just addressed that. So I want to turn to what you perceive as the top priority at Broward Health. I mean, you've been CEO of several systems, you've had various tenures. What's the top priority here as you see it today?
And I don't mean to be circumspect. It's a little premature for me to tell you that, and in my experience, without really understanding the detail of what the community needs, what the organization's strengths are, what its weaknesses are, it would be premature for me to tell you that, and I believe in that very strongly. But in 60 days, you know, I could give you a skeleton vision of what I think Broward needs. But that said, the one thing I feel and I read, because I've been living in Boca for the last 3 months, I think the biggest need is identifying what Broward wants to be and then communicating that either to the press or to the community. And when I say what it wants to be, what is that plan? What is important? So you can walk up to anybody in the hospital and say, what's our most critical 3 things? And they know what it is. It's great clinical outcomes, it's great customer service, and it's great cost of care. And they know how they do those 3 things. And so I'm not sure they know what those most important activities are. So the first step of my role is figuring out that for you. But I just don't have enough of this detailed demographic information that I told Nancy about, or I haven't had a chance to talk to community leadership, so I would be ignorant or arrogant in trying to tell you what I think the important solutions are, but I can make a commitment that in 60 days I can give you a detailed plan.
So I think that's fair enough. So you need to get in, learn the material, and I guess you've hit on some of the factors you'd look at. Can you expand upon what you'd examine to lay out that plan? And I guess what you're saying is that within about 60 days of being on site, you'd have a program and a plan going forward?
Yes, and then you look at the actual services that you deliver, and there's about 40 of them, and which ones are top 10%, which ones are bottom 10%, and why is that? And you try to build off your strengths. But for example, in Lancaster, the reason we built the women's hospital, the one clinical bar we could not move was infant mortality. So we were in the Wall Street Journal for our open heart clinical outcomes, but we couldn't move the bar, so we decided to make a major investment in women's and children's services and aggregating them all at one place. And when we did that, Lancaster went from 3 out of 66, with one being bad, in infant mortality to the top 5 in good infant mortality. You know, we could do C-sections in 5 minutes instead of an hour, and so we mitigated risk to babies. But generally you build off the strengths, but occasionally you have a weakness that if you make it a strength, you jump over everybody else because this was an anchor for you, and now you've turned an anchor into a motor for your boat, and your boat really goes faster now. So I have to understand the detailed clinical milieu of what we do and how we do it.
Okay, and one of the questions I had relating to your performance at Pinnacle was, you've given us some numbers in terms of the improvement from the time you got there till you ended your tenure there. Did that performance remain consistent towards the end of your tenure? I know there were some significant jumps, but there seemed to be some variability towards the latter couple of years. Is that accurate, or?
No, my last 2 years we were in, one of 33 U.S. News hospitals. The second year, one of 65. Not that because we went down, but other people found out what the targets were and they improved their performance. So, Pinnacle continues to be, last year, because that's the only public data available, still has the lowest infection rate, some of the lowest readmission rates, leapfrog aids in all of the hospitals. So the clinical performance has continued to this day, and I'm not there, so obviously it's not me. So what keeps the clinical performance up? And the answer is the culture, the processes. A lot of this is about process. If you make somebody wait 12 hours in the ED, bad things are going to go wrong. If you have a process in place where everybody moves out within 3 hours and they get up to the floors, good care happens because now you've started implementing care 8 hours sooner. We put a sepsis protocol in place that the Secretary of Health is giving to all the hospitals, which is fine with us, and it cut the mortality rates in half. So that process is still there. So it's, while I think leadership is important, the process that you put in place and the training skills and how managers, employees think, that's part of the process, allows that to continue. So Pinnacle's continuing to do very well as they try to digest the 4 new hospitals.
And let's and I think that that's great. I looked at some of the quality care numbers, and I think that's fantastic performance. And certainly putting in the right processes makes sense. If we look at financial performance, and again, I don't know if these are completely accurate numbers, but it seemed that between fiscal years 13, 14, 15, and 16, there seemed to be some variability in terms of net income and EBITDA. Is that correct? And if so, was there any specific reasons why that might have occurred?
Yeah, as managed care grew in Pennsylvania and people moved from Medicare to managed Medicare, we were actually making money on Medicare, which is 1 of 5% of hospitals across the country. But as people moved to managed Medicare and long-term managed care contracts were in place, revenue increases were more and more challenging. So when we brought the radiology group in and they had 5 imaging centers, that was a tremendous plus to the bottom line. But then managed care reacts and they put in very rigorous pre-auth requirements which slowed down utilization. And so the performances in Pennsylvania were still in the top 10 hospitals in profitability, but the whole Pennsylvania market is struggling. If you look at UPMC, the biggest health system, their margin's 1.1, and mine was 4.8 the last year. So that was the 4th highest in the state of Pennsylvania. It's not as good as we had done the year before, but it's all relative. So as managed Medicaid came and paid us less, and managed Medicare paid us less, it was hard to keep the margins above 5.
And Medicare and Medicaid were roughly about 35% of your income?
65%.
65%. So
we were
reversed.
We were disproportionate share hospital.
Okay. And I guess some of what you had to do at that point was enter into cost containment controls. How did you achieve that?
Well, as I said, the most important way to control cost is to have good clinical outcomes, shorter length of stays in the ICU. So if you go from 5 days to 3 days in the ICU, you save $10,000. But we did all the things that a strong organization would do. So for example, our pension was frozen and we were paying our pensioners out of cash flow instead of pulling it out of the trust fund, so that the trust fund didn't have to sell $3 million worth of stocks every month, and they could focus out 6 months. And so we closed the plan, which saved us $3.3 million a month, not to mention insurance. So that's a dramatic savings. We were self-insured, we had a captive. I've been a risk manager for 30 years, so we had low payouts. We managed our employee staffing based upon mathematical measures and staffing grids, and we moved employees where they needed to be. I was waiting over in HR and talking to one of your nice, strong HR employees, and we were talking about his time at Tenet and how they staffed to volume, and we did the same thing. So Wednesdays, Thursdays, and Fridays are very busy, so you bring in additional staff. Saturdays and Sundays are not so busy, and you do it program by program. So if you talk to my references, they'll say the guy just doesn't write a vision. He also knows how to operate. That's why I went to CHI in Fort Wayne. That's why I'm up the road trying to turn around one of the largest LTAC companies. I know what to look for. If patients wait 3 hours instead of 12 hours in the ED, you need less staff. You do a fair amount of research. Our guy was one of the cutting edge in the TAVR study. The catheter valve replacement instead of open heart, and they had just started it when I got there, and the company was ripping us off on the price of the valve, and we were having some of the best outcomes in the country, which helped them in their FDA approval. And I said, well, I notice our mortality rate is 0. There are other places that have mortality of 50%, so we're going to drop out of the study because your price is too high. And what do you think he did? He lowered the price. And what'd that do? Saved us $300,000 a month. So I know that level of detail, but I also write the plan. So nowadays, it's knowing the 150 things to do, training people to do them, and more importantly, training your 200 middle managers to do that on a day-to-day basis, and then you give them recognition. They get the recognition when they make that happen. And I was playing golf last summer at the shore with 11 orthopods, and we looked at the cost of spine. So the lowest cost was $8,800. The highest cost was $32,000. So we had Dr. A, B, C, D, E, and after 10 minutes they said, put the names up there. So they all looked at the difference. What's this guy do and what's this guy do? And the average went from $13,000 to $9,000. So now we made $4,000 in every spine case times 1,500 spine cases. You can do the math. But more importantly, we went almost 2 years without a spine infection. 3,000 cases before we had our first infection. So that saves a truckload of money. So it's this broad-based experience that I have, how to save money on supplies, insurance, staffing, clinical care. It's having all those things happen simultaneously.
Now, within any institution, you're going to have a certain way of doing things. There's the institutional way of doing things. There's, resistance to change. How do you come in and get people to change to the new approach, and at the same time balance the need for retention and recruitment?
It's a balance. It's understanding the culture. That's part of that 60-day learning experience that I talked about. And the cultures at each place where I've been CEO were very different. In Pennsylvania, Lancaster, they had the same CEO for 28 years, so they did it that way. He was very top-down, and literally, if there was a fire back there, before security would put it out, they would call the CEO and say, what do you want me to do? And I'm not exaggerating. And by the time I left 18 years later, people knew what their decision-making responsibilities were, what the processes were about. And once you get the decision-making humming at that 200-person level, I call it a flywheel. You get this dramatic expansion and growth because you're doing 100 good things at one time. The CEO can only do 5 or 6 things at one time. So it's really that training. So it's getting the folks trained, developed, getting them to understand what the vision is, getting pay and evaluation and support programs to support that. So every place I've gone, I have a program called Tell the CEO where anyone, families, employees, would email, what about this? Could we save money here? And I actually write the responses myself, and you'd be surprised what you learn and how fast you can make change. And I think another important takeaway is I never do anything. Anything good in my organization somebody else has done, and they're at the board articulating the TAVR program or why we need a new women's hospital. And when something doesn't go well, I take credit for that. And when you take this fear away from leadership, you know, I'm the coach of the football team. All these years I took credit for the Eagles losing, okay? Now this year I finally get credit for it winning. But it takes the pressure off the Nick Foles, right? It takes pressure off the assistant vice presidents who have young families and they're scared to death. What happens if I make this suggestion? But in my culture, they're rewarded for doing the right thing. Every month I have a President's Award. So if you want to foster cost savings, you give the award to the person who came up with the best cost saving. If you're fostering clinical performance, you give an award for the doctor who's had the best clinical improvement. So these things don't happen by accident. They happen by experience, and everybody wants to win the award, right? So you give, after about 12 months, people have it figured out. I need to improve clinical outcome. I need to save cost. I was telling the young man, nurse practitioners at Pinnacle make $30,000 a year less than they do at Hershey 8 miles away. Why is that? Because we made a cultural decision to recognize our NPs as partners in care. While no other CEO in Pennsylvania would go testify to change the rules so they could practice independently, I did. One CEO out of 220 spoke. So what did that tell the nurse practitioner community? So there's no shortage of nurse practitioners at Pinnacle because they want to work for us. So we could handle the growth in our medical group because we were able to add 100 MPs. But my point is all these things are intertwined, and you have to have done it 4 times to know when you turn this valve what the downstream outcome is going to be. So there's no right answer other than getting the right culture, the right rewards. Then you can attract, like the thing that made Grady successful was our stroke program. And we got a gift from Bernie Marcus, the chairman of stroke at Emory, insisted that it be done at Grady. I was able to work with the Department of Neuroscience to change their rules so this guy could come from Harvard. He comes down. The stroke czar is there. He saved a very prominent man's life the first week, and that's what we used to build the foundation of Grady, and 7 years later, it's alive and thriving.
All right, thank you.
Appreciate it. Thank you. Those were great questions.
Thank you.
Commissioner Whalen, you have a lot of patience today, so you're on the hot seat now.
Good morning, and I apologize that I'm not there in person, but I'll make it easy. You can just look straight at me. You don't have to turn your head. I can see you easier this way. It might be easier for you. I got a couple of questions, and some of the questions have already been asked. So I guess in looking at your resume and listening to your responses, it's clear you've got a very strong background in logistics, operations. You know, that's part of a CEO's vision. You know, I think the other part is how do you take operational expertise with logistics expertise implementation expertise, and then how do you take that and you get employees to buy into your vision and empower them to feel comfortable that they can make decisions, that they can think about ways to to make things better? I mean, what is your approach? Do you meet with groups on a regular basis? Is that a typical strategy? Do you try to mentor individuals on a one-on-one basis? I'm just trying to get a feel for that part of your sort of personality as it relates to the CEO.
Thank you. I'm glad you brought those questions up. The answer is, my father was a school teacher. He's taught 5th grade math in a city school and had some famous students, Chris Dolman, who played for the Vikings, and they still come back and knock on his door because he lives about a half a mile from the school. And so I'm a teacher at heart. So depending upon the HR infrastructure, the college infrastructure. So I've always had a mentor program, and I actually mentor 2 people. So the folks I mentored at Pinnacle were the administrative director and the number 2 guy from the internal medicine residency program. And I picked them purposefully because one of the programs that wasn't humming was our medicine program. We couldn't recruit the caliber of residents that we want. So I personally trained and worked with them, and unfortunately I trained the associate director too well. He got a big job in Orlando, and so there's an official mentor program where everybody at the VP level or above takes 2 mentees 2 hours a week. I meet with employees monthly for lunch with the CEO. There's no script. They get free lunch. They tell us all sorts of things, and I communicate the plan. And then quarterly, I have what are called state of the system presentations, 5 in the morning, 2 at night, noon, so people can come and we talk about what's important. But at the same time, you have to tie it into the performance and human resource system so that the things that you want to achieve become the important goals that you want them to achieve. When they hit their goals, the organization hits their goals, and it's tying those things together so they understand what the plan is, they understand what's important. So it's mentorship, a formal program, it's a formal program of communication, it's formal program of house organs, internet, websites, and it's just teaching, and it's teaching the medical staff, both the formal and the informal medical staff. So we had a number of educational sessions on that spine discussion before we put the information. You just don't walk in and throw it up on the screen and say, hey, you're number 8, why are you $32,000 a case? You have to spend some time at the executive committee talking about targets and things like that. And so it's interesting, our one hospital had we had a very large orthopedic program, but the one hospital has slightly elevated infection rate. So the chief of orthopedics, for free, got the guys over here to agree to watch him do cases, and he identified a break in technique. I've never seen that in my professional career. I wouldn't even have thought of that, but that's what you learn by talking to people. The doctors were in the room, they said, oh yeah, we'll do that. But they knew what the importance of clinical outcomes were. So it's setting together a very formal program. In Lancaster, because we had F&M, Franklin Marshall, a very strong liberal arts school about a mile away, we had a very formal management process. And if you wanted to be a VP, there were 26 courses you had to take. And guess what? So the head of radiology wanted to be promoted to a VP, and I said, oh, you're short 2 classes, we'll have to hire somebody else. And what do you think happened after that? The classes filled up. And we actually wrote the curriculum of what we thought was critically important to be a middle manager. So that takes a lot of time and a lot of effort, but at the same time, now they know what the thinking process is, now they know what's important.
Okay, good. The second thing I think is critical, for me, is understanding what your sort of focus would be when it comes to, say, the community. We've got various constituencies within our community with different perspectives on who Broward Health is, what our mission is, and these could be difficult conversations. So how do you think you best approach those? Do you do that as a one-on-one? Do you try to do it on a town hall session? What's your preference in addressing various constituents who have various opinions of what we should or should not be doing?
I think you start by listening. Some of it's one-on-one, some of it's in community forums, this board in itself and the way it's structured with public meetings. You learn a lot in a group setting, but I think you have to do all those things simultaneously. Otherwise, it's quite an elongated process, and you'd like to have the success that we'd all like to have, I think, in a shorter period of time. So you have to spend a lot of time, 6 a.m. at restaurants, 9 o'clock in community rooms, listening and doing. Sometimes it's great one-on-one, sometimes it's great in a group, and you'll all help me understand how to do it and who those people are, because it'll take me a while to learn the community. And then lastly, there's always going to be disagreements. I mean, we had some folks who made a career and their political career out of bashing Grady, and early on it was very, very, very difficult. But after 4 years, we were actually friends, and he agreed we did tremendous things for the community. He still bashed because that was part of his political niche, but at the same time, when we actually needed things and there were close votes, he would vote for Grady. So I think it's learning and understanding, and these presentations, the state of the hospital presentation to a community group's obviously a little higher altitude than it would be for a group of department heads or doctors, but you have to do that.
Okay, and I just have two very simple questions, and take them one at a time. A, if you looked at your career, what do you think your greatest accomplishment has been? And then secondly, what do you think, has there been a place where you've misstepped that you've learned from, and how did you approach recovery from a bad decision? Because I think you learn as much from a bad decision as you do from a great decision. So, if you could just answer those two, just kind of get a sense of your perspective on those.
I think the best thing that I've done in my community is, to your question about development, is the number of CEOs and COOs and CFOs that have developed by working with me that are around the country who've done extraordinarily well where they are. My CIO followed me from Buffalo to Atlanta to Lancaster, as did the CFO, so that gives you some idea of the enjoyment that they had with working on our team. And then just watching all these department heads become COOs. I took a young man, smartest young man I've ever seen, and he lived about an hour north of Harrisburg, and I said, "You're really smart," and he worked in IT. I said, "You could be a COO, I want you to get a master's degree," and he says, "Well, that'll take 3 years." I said, "No, that'll take 12 months, I already have you enrolled." So he took the classes, then we bought a small hospital 2 hours away, and I made him the COO. And I took the CEO of a FQHC and said, "Would you be the CEO of our hospital and your FQHC, and would you teach him?" And I taught him, and now he's the CEO of this small hospital, and they love Pinnacle Health and all the things that we've done. So that's the most positive thing. The worst thing that happened to me, I was CEO about 6 months in Lancaster, and remember I said OB was not our strongest suit, but we had one of the best family practice programs in the country, arguably in the top 5. We could recruit 15 top 10 American medical school grads to Lancaster, Pennsylvania. It was amazing. That's how good it was. But each senior had to do 50 deliveries a year, times 15, that's a lot of deliveries. So they had a hard time meeting that need. And when family practice doctors do babies, they have to have OB support, and we had 12 OBs who shared backup call, and one guy wouldn't show up. And one month we had a near bad miss. Another obstetrician just happened to walk in the OR and did the C-section. And then we had an event where we did have a bad outcome because he wouldn't show up. So I decided we wouldn't do that again. So other than telling one board member, I went out and recruited 2 OBs to do nothing but support family practice. And they showed up on Monday, and there were 800 doctors at the board meeting, at the medical staff meeting on Wednesday. On Wednesday night, the chairman called me up about 11:30. He said, well, young man, you can go to work tomorrow because the executive committee believes so strongly in what you've done. So what I learned there, when you have major issues with the medical staff, you communicate them to everybody. So now you'll probably say, you don't have to tell me that, we already know that. So I learned to over-communicate.
Okay, great. Thank you. I think everything else I had on my mind has been covered, so I appreciate it.
Thank you.
Just a few questions real quick before I go into your closing remarks. Where would the quality begins in the healthcare system?
The quality really comes from measurement, actual clinical scores. 15 years ago, you would hear, well, my patients are sicker than your patients, but now we can adjust all those things. So it's really pulling together the measurements, and then you get the right people together, the official and the unofficial leadership of the medical community. You get the nursing leadership sitting in a room, and you begin sharing the information. And mysteriously, just by sharing the information, the bell curve tightens. And then you begin to formally study, why are the people way over here on the left? Why are they over here? What is the actual clinical difference of who does what? What supplies do they use? How do they do things in the operating room? And you get teams to do it, and then you make tremendous changes. And then when somebody hits a national benchmark, you give them the President's Award, and everyone wants the President's Award. And it's all part of this milieu that I talked about. And then you get the board asking questions. You get the right board person. The person who chaired our quality committee was a retired dean of nursing and from a local college who could ask the right questions, and I could ask the right questions, and I could prep her. Why is the mortality rate different on Saturday than it is on Monday in STEMIs, right? I knew what the answer was. I didn't go in and say, here's the answer, but she asked that question. And then the chief of cardiology and the president of the cardiovascular group began working and began modeling, and they changed the model so that on Saturday it was exactly the same as Monday. What do you think happened to mortality? It dropped by half. And then they go to the executive committee, they talk about how their mortality had dropped by half. And then the head of the hospitals program said, you know, our sepsis we don't have a sepsis protocol. Everybody wings it. I've written a sepsis protocol, and we've been trialing it over our East Shore hospital, and mortality's dropped by half. And what the chief medical officers, the other 2 hospitals do? Give me the protocol. And then you put the protocol in the computer. So when the doctor sees it's sepsis, he hits the sepsis orders, and they're all done. So instead of taking 30 minutes to write orders, the computer automatically spits out to nursing, so pharmacy gets the order quicker, and on and on and on. So it's really getting the doctors excited about it. And so I told you about this dinner, and I was just sitting there, and they were arguing who was better at rotator cuff, because one guy did them open, and he was $983 cheaper than using the robot. But the robot got people back to work 2 weeks sooner, which is better for the employee, and which model's better. So I just sat there like this, and I let them talk about it. And that's part of that cultural change that I talked about when your doctors are or I'll give you an example. We reduced our opiate use in our practices by 25%. So think about that. And I learned about, I was playing golf with the head of the IT cybercrime group for the state police, just happened to be one of my golf partners. And he said, yeah, we're watching this pharmacy because you have these two guys who write more prescriptions than all the other doctors in the county combined. So we have our group look at it, and sure enough, they wrote more than 300 doctors combined. So the president of the medical group put together a protocol, and we began measuring and sharing data, and that alone made the curve move. But then more importantly, when we found the patients with really high doses, there were about 8,000 of them, 5,000 of those 8,000, and we began randomly testing them, 5,000 had issues. Half of them didn't have any in their blood, so what's that mean? And the other half had that drug plus 5 others, so we pushed them to treatment and we cut down the volume. So it's really understanding where to get the data, it's understanding who to get in the room, it's understanding prepping the people who can ask the right questions in the room.
So the genesis of quality, it reverts right back to the patient and how
Yes.
they do it. I'm not going to ask you about how often you run, because you touched on that. Regarding the community, I hear what you have to say. I heard the issue about it's just like I tell our folks in here, I'm just directing the orchestra. Our job is just to make good music. I don't care who plays the drums. And so in reality, you mentioned that who cares who gets the credit as long as the work is done. I'm a firm believer on that. The issue, we are a tax-funded organization, but our goal has been, and I know that this is a trend that's been going on for a few years, and then for the last 4 years that I've been here, we follow through. Actually, we like to make the things that work that are profitable work for us, and then eliminate eventually. Our goal has been to eliminate the tax burdens on the taxpayers, because like the South, their millage rate is just hardly anything compared to ours. So would that be something that you would be consistent with your philosophy, that we can be very, very profitable hospital and without taking away from the community care, the behavioral health, the substance abuse, all these other things that we need to do for those who cannot afford to take care of themselves?
Right. So the answer is absolutely yes, and I apologize. I was thinking here. The tenet of my philosophy in every place I've worked, and I learned it at each, and combined, I wake up every day answering to the patients. That's why I have to tell the CEO. I get emails. My husband's waiting in the ED. It's been 4 hours, and I walk over to the ED and we see what happens. So everything I've said is really based off the tenet of you take care of the patient first. When you take care of the patient, you're doing these community activities that you described. So I would say you can be profitable. I don't know what really profitable means, but I don't think our goal is to be real profitable. Our goal is to be profitable enough to keep the spiral going up that I talked about. But the year before I went to Grady in Atlanta, Fulton in DeKalb County gave the hospital $110 million. The year I got there, they cut it to 60. So we got the hospital to break even, so they reduced it to 48. So we got the hospital to break even. So we saved the taxpayers over $50 million a year, and care improved dramatically. So that's where I learned the model. You do the right care, it's much less expensive. And we expanded our community services. We gave away $2 prescriptions if you were a Fulton County resident. So we had 110 pharmacists manually counting pills. And we had to take our auditorium, and that became the waiting room for the pharmacy. It was all manual, it was all paper. So our second gift from the big foundation was $5 million. We took it and we bought a warehouse, and we bought a computer, and we bought all these rags, and we started dispensing, and we type in the order. Well, we had to put the computer in first. A bottle would plop down on the conveyor, would go to the right place, it would drop out the pills, it would go to the end of the line. There's a little camera, would have a picture of what's in the bottle. It would weigh what it was, so it knew if it was 50 or 51 pills. So we could tell you, Mr. Rodriguez, your prescription will be done at noon. Before that, you would have to sit there all day waiting for your prescription. And oh, by the way, we saved 100 pharmacists, because that's how many pharmacists. We gave away 2,500 prescriptions a day. That's the equivalent of 10 CVS's, okay? So can you picture the crowd of people? So we did it electronically. We could tell you, you could plan to pick it up, and care got better. So with that 10 pharmacists, and a pharmacist is $150,000, we built 3 new primary care centers. So they're all part of that broad operation. You're successful, you meet more needs. You meet more needs, you become more successful.
Well, that's what I was saying about subsidizing the poor folks out there by being smart in our valuation and other factors. I didn't mean to be a for-profit hospital.
Correct.
I'm just saying, if you utilize it, there could be a lot of waste that can be cut down, could be more effectiveness, and
I think that's a good point. And as I said, I have the responsibility, and I learned in Buffalo and Atlanta, I work for the taxpayer as well. So I have a responsibility to treat every penny as if it's my own. And I'm in the for-profit world, and I have no expense account. You know, I don't need a secretary. I don't have any trappings. You know, I always kept the old furniture of the prior CEO. That comes from the top. And when the organization sees me acting appropriately and thrifty, there's a difference between thrifty and cheap. You want us to be thrifty, but not cheap.
Exactly.
But at the same time, if you do prenatal care and you have a healthy baby, you don't spend $50,000 on the NICU, so you save the community or an employer or the government $50,000. You do that a couple of times, that pays for a lot of program.
And thanks. And one last question. Suppose now you're getting close to the final line here. Suppose you are chosen for this job. How long could you be on grounds? You mentioned that you were living in Boca. You permanent home in Boca now?
No, I'm helping this long-term care company.
Okay.
I could be here in 30, 60 days.
Okay. All right. Well, I thank you, and I don't want to take any more of your time, but if you would do your closing remarks now.
Sure.
And by the way, you can go golfing with him. I'll go shoot birds with you.
All right. Thank you.
This is boring stuff.
It's been my pleasure to hear a little more about Broward, and I would say your questions were about as good as they can be from a board of directors. It shows you're committed. It shows you understand. It shows the issues are top of mind, and patients are top of mind, and that's what I'm all about. And my wife is a nurse. I started out as a risk manager, and we were self-insured, so I learned how care was delivered, and so I understand how patients should be treated. So one of our measures will be, is every patient treated like your mother? If you treat every patient like your mother, it'll be great. And if you build systems to deliver that, I'll leave you with this thought. I was at a major medical center where I used to work, and my sister-in-law was dying of metastatic cancer. And she hadn't seen an attending physician, and she happened to be in a room that I painted in 1984. And this was 2007. And it still had the same pink border that we were putting up, and the disease was in her lungs, in her brain. They had done an 18-hour experimental operation on her spine. It was in her legs, and both of her femurs had broken. And so my wife wouldn't let me get involved. So finally she had this experimental surgery. We got in the car, we drove 10 hours to a major East Coast city. And so I'm there, and the fellow is there, and he's talking about they're going to do this and they're going to do that. And I said, have you mentioned hospice to the family? And his face turned white. He said, no, I hadn't thought about hospice. I said, it's in her brains, it's in her lungs, it's in her spine. She can't lay in the bed because you opened up her bag, and she has rods in her legs. She can't lay on her side. So about 10 minutes later, the attending comes up, and so I put my CEO badge on, and she goes, oh, Mr. Young, we were just thinking hospice would be great for her. So she made arrangements. My sister-in-law went home and died the next day. A horrible death. So if you put programs together and you're thinking about communities and patients, it was a hot summer in Harrisburg last year, and one of the VPs pulls up for our 7 o'clock meeting, and in our back seat is an air conditioner, and we did the geriatric care for a high rise. And I said, what's that for? She said, well, this little old lady had her air conditioner stolen, and it was 100 degrees, and her house was 105. So we gave her an air conditioner, okay? So it's understanding patient needs that's different in the way I think. Couple that with the ability to 4 times pick the right vision for the institution, and they weren't the same. It's not, you know, you have to shoot, everybody has to shoot 3-pointers. If you have Kareem Abdul-Jabbar, you're going to set up the hook shot because he's the best ever at it. And it's finding out what we're the best at and building off of that, taking the 1 or 2 weaknesses and make them great, then you leap ahead. And if you're focused on the patient and you're focused on the community and you make your weaknesses strengths, all the other things automatically come together. So it's process, it's experience, it's working with people. I mean, Pinnacle wins best places to work every year. Why do MPs work for 30% less? Why, maybe I'll leave you with this thought. The last 2 executives I recruited at Pinnacle were compliance office. And by the way, I have compliance experience working at CHS. I was president of their medical group while I was there, and they had compliance issues of a large magnitude, so I learned how to do that. But the 2 candidates for compliant were the chief of a major southern medical school who has a great basketball team. I won't give you any more. And the other one was the chief of compliance for the Robert Wood Johnson Foundation Hospital. Okay. And I said, why do you want to come to Harrisburg? The city's bankrupt. She said, I want to come to Pinnacle because of what you've created and what you did at Grady and what you did at Lancaster. I want to come and work and learn with you. And so I've watched over the last 4 months who you've hired. You've hired some heavyweights. They're very good, okay? Imagine with some mentoring and development and program development how great they can be. And when they're great, and hopefully the same learning can happen with the medical leadership, imagine where we can go. And then everybody wins. The taxpayer wins, the medical community wins because when they show up at 8 o'clock, the case is ready to start. The patients win because they're not getting an infection. The community wins because they have a program that they need. The VPs who get credit wins. Everybody wins but me, and that's okay. So I appreciate your time. I'm sorry I'm a storyteller. Thank you.
Thank you, and I would say, well, you want to, he's going now to,
Absolutely. Thank you so much, Mike, for coming down. That was great to hear your vision. The next stage is really to go and meet our system leadership over at Broward Health Medical Center. Tori Drakeford, my VP of HR, who you met.
He's great. And Avioli has been spectacular. She's kept us well informed. You really have a nice team.
Oh, thank you so much. Thank you, Ariella. Thank you, Tori. All right, so
Thank you.
that's the plan.
Good luck.
thank you. The best.
Thank you. Appreciate it.
They can do a public raffle. According to the thing.
Hi, Commissioner. It's Chris again. How are you? With IT.
Terrific.
Good. Are you all planning
No,
on
no,
meeting
we're not
after
done
this?
yet.
You're not done. That's what I thought.
We just like to,
What did you discover?
Okay. Wanted to double check. Are you hearing everything okay? Everything is good?
You're perfect. That was great. And
Perfect.
Really an easy way to do it.
Commissioner Wells.
It seems you guys can hear me, so that's perfect. We'll do the same thing tomorrow, hopefully.
We will. We'll leave this. I'll be leaving this set up, so I will work with you tomorrow to get you connected again.
Can you see me?
Okay, perfect.
Commissioner Whalen?
Yeah.
Here, I'll have to turn the camera.
Commissioner Whalen, if you give me a second, please, before we adjourn.
Here we go.
You want to address them?
He can see you now.
Okay.
How you doing, Dick?
I have to, I just want to let you know, we will tomorrow interview the other two candidates at,
Yes.
at the same time, so we'll be here at 9 a.m., okay? And you're going to move the snow away from your front door so we can see you with your skis on?
I don't know if I'll get out on the mountain, but hopefully at some point. I would have liked to announce it this morning when there was about 2 feet of snow out there, but it didn't happen.
I hope you got some Cuban coffee up there to keep you warm.
Well, I've been up since about 4:45 getting ready for this, so I need some coffee now to stay awake.
All right, as soon as I'm waiting for Commissioner Yuri to get back here, so I figured that he's not coming back yet. So anyway, we will meet at 9 o'clock, and we'll go through the other two candidates, and from there, I guess we can probably after that, since first I want to thank you for helping me on the search. When we were tasked with this job, we talked about January, and I believe that we're like maybe a week or two behind schedule, but it seems to me that we made it, and I hope that by the 31st we will have solidified who is going to be the CEO. Commissioner Yuri, I'm waiting for you to adjourn. Before I can adjourn, I need to have a quorum.
I asked if I could go to the building, and you said...
I know.
Mr. Chairman, I apologize for not getting there today. It was beyond my control, but I will be in town next week where I didn't think I'd be able to, but I will be there next week for all the meetings.
Okay, so we have a meeting tomorrow, and then we have a meeting Wednesday, right?
What's that?
No, we have meetings on Wednesday,
Yeah, this week.
this week. Are you gonna be here this week?
Yeah. No, I'm gonna be here. I won't be there till Monday, because I was planning, I will be in town next week. I just won't be there this week because I couldn't get there until maybe tonight, but I couldn't get on the flight anyway, so tomorrow I'll do the same thing, and then Wednesday I can either do it by this way, or I can do it by cell phone or phone, whatever works for you guys.
All right, okay, so anyway, again, just thank you very much, because you were instrumental in, they went through, we didn't vet these people as a company in Georgia. Went through more than 300, and we came up with the 10, and you helped me a lot getting to all the, to all the hoops there. So, anyway, so do I have a motion to adjourn?
Motion to adjourn?
Okay, all in favor?
Aye.
Okay, we're adjourned
Aye.
till tomorrow. Let me do the,
Thank you. Good night, everybody.
take care.
Take care.
You know what I gotta sign here? Yeah?